Thank you for your attention. I know it's been that's a lot of didactic lecture, and I'll work through this part, and if we've got a little time, maybe Julie, before we break out into groups and go for the break, maybe Julie Foreman can give an introduction to the nursing care model that we have at Crosstown, which our nurses are really what are key to the care that we provide. And the care that we provide, it really is based on relationships and knowing our patients and getting to know what is important to them, what they value, and how we do that. We depend on the nurses and our frontline staff. And if this, when you expand this into your clinics to care for this group of patients, it is particularly important to engage them, and we do that with client-centered care, which we'll talk about. So I want to identify that incarceration is a risk, and we'll talk about how that is relevant for this population. I'll talk about initiation and what is a safe and effective dose and how we do that. As Nadia, Dr. Fairburn alluded to, we've adapted our initiation schedule somewhat due to increased level of tolerance that we're seeing in our folks who've been exposed to fentanyl. I'll talk about client-centered goals with a case illustrating one approach to that. And I think this is how we get to know our patients, and the tools that we use is one area that we could get more information and develop better tools on, in my opinion. And what is treatment effectiveness? Well, we've got who else better to ask but our patients and participants, and I'm glad that we have them here today for their comments. And I've got a few quotes from Salome to illustrate some of those some of the themes that we've identified. In talking with the coroners, it's become clear that fully 2/3 of the folks who've died from opioid overdoses have been incarcerated in their lifetime. And we've all known that the risk of overdose and death is increased when people are first released from prison in those first hours and day. But in fact, that risk for overdose and death continues for years. So I think really what we're seeing is that incarceration is a sign of undertreated illness. This is looking at our Salome participants. 80% of our Salome participants have spent at least a month in jail at baseline. On average, they've spent nearly 40 months in jail, and there's great variation in that number. The men in our cohort have spent more time in jail, and as I mentioned in the first part, they were engaged in illegal activity at baseline to Salome, on average 14 days out of the prior month. And then within 6 months of treatment, that illegal activity was down to less than 4 days a month. But when we're assessing who needs access to injectables, if somebody has been involved with the criminal justice system, it is a reason to get them into care and intensify their care. And we're asking that now, and people reflexly, I think, sometimes ask, oh, is that going to be against, is that going to work against me? But in fact, it's exactly the opposite. We think it is a reason to get people into care, and if that's intensified care, so be it. Now I want to talk about what is an effective dose. And one thing I want to do, and I'll try to illustrate with this graph, which shows average dose of either diacetylmorphine or hydromorphone expressed as equivalents against the day since treatment initiation over the 6-month treatment time in Salome. And over the first few weeks, month or two, doses increase, and we can see that on the graph. But then the dose just levels out. And there's sort of a myth or an assumption that people's dose will just go up and up and up and up. But in fact, the dose just levels out. And you can see on this graph, which is prescribed versus received, people actually receive less than is prescribed. And there's a few reasons for that. One is they may not come for every session, but we frequently have people saying, well, I don't want the full dose today. And our nurses at any time can reduce the dose if somebody's not feeling well or they just don't think they need as much that day. So if you're developing your programs, the one thing, people should always have the option of reducing their dose if they want to do that. So reassuring. You can get people to an effective dose, and it's not a struggle or a fight, people wanting more and more and more. I can reassure you that's not the case. Adverse events. Our adverse events were, and our serious adverse events were all expected. Mostly histamine reactions. So you can anticipate that people will have either localized histamine reactions where they're injecting or broader, but it's not an allergy. Doesn't mean that they need to stop treatment. These are generally manageable locally with a cool pack or some Benadryl. Thank you, Russ. And then oversedation, of course, which is a predictable event and also manageable. Hydromorphone, surprisingly, had less adverse events and serious adverse events than diacetylmorphine. And as Dr. Fairburn illustrated in her presentation, I'm just going to express the data slightly different here. But out of over 88,000 injectable treatments during the 6-month treatment phase of Salome, our nurses only had to intervene with oxygen or Narcan 14 times. And there were also 11 seizures in 4 patients, and those were all managed successfully on site. The seizures were all in people receiving diacetylmorphine. So I think there's risk of seizure with any high-dose injectable opioid, but it may be increased with diacetylmorphine. So a consideration if you're starting people on treatment who have a seizure history. This is our current initiation schedule, and we've accelerated starting people on a slightly higher dose and going to potentially a higher dose at the end of the 2nd day. And this is in response to fentanyl effect. We've just found that people who've been exposed to fentanyl have higher tolerance, and with their pre-fentanyl initiations, they just did not have they weren't comfortable enough, even after the first test dose. And we had some people saying, I'm just not going to be able to feel well with what you're providing, and wouldn't stay for a 2nd dose. So we've started a little higher. We now start at 20 milligrams, and we increase a little bit faster and go up to a maximum of 130 milligrams after the 2nd day. And I think it's one reason why we'd like to build a community of practice and be able to discuss ideas, because this evolved very quickly with the advent of fentanyl, and as other opioid analogs enter the market, we may require further adjustment and assessment. I want to talk about smoking, because we don't. Yes, we provide intensive opioid treatment, but that's really just a very small part of the care that we provide. The vast majority of our patients in Salome and at Crosstown are smokers. Over 90% were identified as smokers. And what's interesting to me, and while we need to address smoking, is our folks who were most severe smokers also had the most severe chronic disease. So when our folks are sick, when they're dying, it's from complications of their smoking. So it is vital that we address smoking, and that's one thing that we work towards. And we're fortunate in BC that smoking cessation products are part of are covered by pharmacare and available. A case example. And this is not a specific case. It's sort of an amalgamation, and there's no way that anybody's going to be identified or singled out. But I think it focuses on a number of themes and commonalities that we see in our Crosstown patients. So Ms. MJ, who's 38 years old, started at Crosstown. She has a diagnosis of severe opioid use disorder. She's originally from Ontario, and she identifies as Aboriginal. She suffered serial abuse and trauma in her childhood, and she's used injectable opioids since age 17, over 20 years. She has tried methadone at least 5 times, up to 150 milligrams, but continued to use illicit opioids and heroin. She has tried detox and residential treatment a number of times, but relapsed to illicit opioid use after her discharge. So she started at Crosstown. She's had overdoses requiring resuscitation with Narcan. And I think that's an important question to ask as well. I think generally people are, but if somebody's had a resuscitation requiring Narcan, they are at risk for overdose and death. They should be offered whatever treatment will get them into care, whether that's methadone, Suboxone, slow-release oral morphine, or an intensified injectable option with hydromorphone. She reported sex trade work in the past. She's had criminal charges due to illicit activities to obtain opioids and prevent withdrawal, and she also required hepatitis 3 through needle use. At Crosstown, she's coming twice a day, and she's stopped illicit opioid use. She's also stopped illegal activities. She has obtained better housing. She reconnected with her family, and she's working part-time at her housing. These are typical outcomes after several months in treatment at Crosstown. And then, like I said, I think it's important that we identify what's important to people. And one of the ways we do that is developing long-term and short-term plans. In the short term, she wanted to see a dentist. She was working on getting ID and didn't have any ID. But before she gets her ID, she wants to get a haircut. She would like to see psychiatry regarding stimulant use. And she's interested in long-acting treatment with dextrogen spansols. And I've added a reference here. Some of you may already be shocked that we're providing injectable treatments. But in the heroin-assisted context, with the intensive and supervised model that entails, there is one study out of the Netherlands showing reduced stimulant use and reduced cravings for people that are receiving heroin-assisted treatment when they're given long-acting dextrogen. And we're sort of using a range of 15 to 60 milligrams twice a day when we've seen good clinical effect with people reporting less methamphetamine use. And we've also noted improved behaviors and better tolerance of the treatment that they're receiving. One of the Dutch investigators, Wim van der Brink, went so far as to say, for anybody that's using stimulants and in heroin-assisted treatment, we should be proactively offering them dextrogen as part of their care, because stimulant use is a predictor that people would do less well in care. She's a smoker, so she's willing to consider nicotine replacement treatment and would try a puffer, but she's not ready to do that today, and she's applying for her status card. Longer term, she wants to get her ID and her status card, and that's one thing we can help people break down. What's the first steps in reaching a goal. She's like to get dental work done and maybe dentures or implants. She'd like to work more, but she's not ready to work full time, and she'd like to get her Hep C treated and cured. I just like to identify some of the themes that people have identified for why they see this treatment as effective. And I just acknowledge Heather Palis, who's one of the PhD students, and has assisted with the interviews that have been done with our participants in Salome. So there's sort of eight themes that have emerged for why our patients identify that this treatment is effective for them. Improved health, improved quality of life, stopped or reduced street use of opioids, stopped or reduced illegal activity, reduced craving or withdrawal, spending money on things other than drugs, and the model of care that we have at Crosstown. I'm going to highlight a couple of these with some examples. So firstly, improved health. And this participant identified that everything in my life has changed. I have housing now. I eat every day. I'm sleeping better. I'm way healthier, less stressed. I have a cat now that I spayed and vaccinated and take care of. I haven't had a pet in 10 years because I was too all over the place mentally. I also have regained my relationship with my mom, my siblings, my kids, my partner. I was so wrapped up in addiction that I became a non-person. Now I'm woken up, I'm back. One of the other things is improved quality of life. And this participant says that I'm very content with what I'm getting and the whole program. It's given me time to reflect on things I was too busy to reflect on before. Being wired is a full-time job. Getting the coin, scoring, enjoying the high, it consumes a big part of your day. Now I have more time. I'm finding more things to do I like cycling. I'm helping one of the other participants become a better reader, hanging out with friends, playing pool. And then stop or reduce illegal activity. I'm taking care of business now, getting my life on track. Of course my money situation has improved, healthier now. I was doing crime before, and now there's no need for money, for doing whatever to get money. I have a choice now, and I choose to do hardly any crime. And finally here, model of care. See, the thing about the program too is it's not just the whole group of support. It's the dietitian, it's the doctors, it's the social workers that help you get housing, help you get ID, help you hook up with your families again. There is such a big program of support around you, and they help people build their lives again in a very strong way, and it's really effective. The staff go above and beyond. It's just amazing. They help people with their medications every day, help them with appointments. It's a very big picture. It's not just about the initial drug. Like when we have problems, there's always a sympathetic ear there. It makes us feel more valuable when you're out here on the street and you don't feel much value a lot of the time, the way people treat you. So I'm going to wrap up there, but our model of care is essentially we honor the individual and respect choice. We need to engage our clients. That's essential, and building and maintaining that relationship is vital. and that our care needs to be patient-centered at all times. We need to identify what's important to people, get to know them, and provide care in that context.